Hello, welcome back to my channel. And in this video, I'm going to talk about white matter. What's the matter? And the matter that I'm going to talk about is the myelination on white matter, um, how it appears on MR, and also focusing on DTI, the diffusion tensor imaging on brain MR. So let's jump in. I hope you enjoy. First of all, myelination. This is important because the brain, how the brain looks, is represent the myelination in the white matter. So if you remember in math school, why the gray matter is called gray, white matter is called white, because the gross anatomy, the white matter is whiter and the gray matter is grayer. So both gray and white matter are similar as they are both essential sections of both the brain as well as the spinal cord. However, gray matter plays the most significant part in allowing humans to function normally daily. And you know that gray matter makes up the outermost layer of the brain. And the gray tone itself is due to high concentration of neuronal cell bodies. And I will explain it to you later, what's the difference between the two of them. So if you remember, or if you're still not a radiology in training, or I mean residents, well, our teachers always said that on MR, the T1 represents anatomy. We always have to look at the T1 sequence to know the anatomy. Because why? Yeah, it represents the anatomy. So it's simply a reminder, and it's simply kind of a thing to remember that white matter represent whiter on T1 anatomy and the gray matter represent grayer color on the T1 MR. And that's basically the anatomy. So the gray matter consists of unmyelinated axons and neurons, bunch of neurons, cells. And white matter consists of myelinated axons. So this is the difference part. White matter consists of more myelinated axons, and myelin is fat. So can you relate to me now that why it is white matter is whiter on T1? Because it consists of fat, and fat is on T1 is hyper intense, while gray matter more like bunch of neurons. It's heavy cells, so it's more like dense grayer. And that is why that you have to remember, instead of looking the CSF color, you can always look at the white and gray matter on T1, that the T1 gray is grayer, such as the name, and the T1 on white matter is whiter, just like the name, because it is fat. Fat is hyperintense on T1. But this is not going to be the same if you are looking for a newborn brain MR or like kids under 2 years. That's a bit tricky, and I'm going to explain it to you because the myelination just began. And the newborn head is like more, the white matter is more watery. So it's simply progressing from water into fat. And we can look mature myelination on T1 brain MR at 1 years old, but on T2 at 2 years old. So if this is a progress thing that always developing, there are few simple general rules that I always remember for myelination progression, which is central to peripheral, caudal to rostral, dorsal to ventral, and sensory then motor. That's four rules that you can always Google or like search it in journal or textbook. And what is the last thing to myelinate? So just quick jump to the answer. It's the peritrigonal white matter. It's going to be matured until the age of 20 or 30 years old. And what is the best sequence to visualize certain track? Because white matter consists of fiber, lots of fiber track, and we have to know the best sequence. I'm not talking about DTI here. I mean like the conventional thing. What is that? And the answer is T2 flare on T3 Tesla MRI. This is a timeline from newborn 1 year and 2 year. And if this is the 50 shades of gray of T1 and this one is for the T2, At newborn, you will looking at white matter. The color of the white matter on T1 is grayer, while on T2 is whiter. While on 1 year, you can simply looking the white matter is whiter, which is mature enough, but not on T2. On T2 is slight whiter, so it's more watery, it's still not fatty. And on 2 years, it's going to be mature on both sequence. And T1, it's going to be wider because white matter is wider, such as the anatomy said. And the T2, the white matter is not that wider, but it's grayer. Okay, so this is an example. Here is a neonate T1. Look at this. Look at this white matter. The white matter on T1 is grayer, and on the T2 is whiter. So it's like watery brain. Such as the fatty progression begins, the myelination begins, it's going to be mature like this. The white matter on T1 is whiter, and the gray matter is grayer. And here's on T2 mature, here's the white matter is grayer. Look at how the difference between the neonate and the mature. And here is another example. If you can guess, is this a mature or immature? First, look at this white matter here. You can see that the white matter is grayer, so it's more like similar with this neonate brain. But why is this area is hyper intense? This area is internal capsule, right? And internal capsule is white matter, but here is the basal ganglia is the deep gray matter, so just ignore them. In internal capsule is white matter. So why is this white matter here is hyper intense? Is this mature or not? Is it a newborn? And yes, this is a newborn and is a term newborn. So you have to know that term babies have this. They have myelinated posterior limb. So you can see this here. There's the posterior limb of the internal capsule. And the others that might already myelinated is the brainstem, cerebellum, the optic tract, and perirolanic region. And this is okay. So that's the basic of white matter myelination of the white matter. I'm not going to talk about the certain abnormalities of the myelination and dismyelinating or demyelinating disease, but in this video, I'm going to be more focusing on the fiber tract, on the DTI. So there are three large groups of fiber tract on white matter. We group it into this projection fiber, which is project distally from cortex to spinal cord, such as that, corticospinal tract. Commiseral fiber, which connect two hemisphere, like the corpus callosum, the anterior and posterior commissure, and also the last one is association fiber, which connect different cortical areas within the same hemisphere, such as the cingulum, SLF, and ILF. So this is the color palette. But just remember, this color palette is the conventional color palette. So I bet in like 5 years or even now, I saw some DDI MRI that has different color palettes because this is just a conventional. If you understand the basic and the principle of the track and the DTI color, so you won't be confused by the conventional if the conventional color is turned into somewhat more like other colors. But yeah, we are going to assume that this what apply the conventional color. So first of all, the blue represent the projection fiber, which is project from spinal cord to cortex to the spinal cord, which is like going up and down. And the commiseral fiber here from connecting between the two hemisphere, like the corpus callosum, such as that. And the association fiber is going forward or backward in the same hemisphere. So if you are really having trouble to remember this, just Remember that the sky is blue and the sea, yeah, it's not that blue, but yeah, assume it. The sea is quite blue. So when you look up the sky and you look down to the sea, it's going to be blue. It's a blue projection fiber going up, going down, going down, going up. On the commiseral fiber, it's red. So just imagine you are on a traffic light. If the traffic light was red, you'll stop. And when you stop, you have a time to look to the right and to the left. But if it's green, you have to go forward, just like this. So going forward, going backward, it's on the same lane, on the same hemisphere, is going to be association fiber. But going right, going left, connecting between the two hemispheres is commiseral fiber. But yes, you'll see that it's not only these three simple colors. But why is that? Because there is an overlap and orientations, an oblique orientation. So the overlap and the oblique orientation fiber might produce some of mixing color from the original fiber track color, such as red and blue will produce magenta, green and red will produce yellow, and green and blue produce cyan color. Okay, I'm going to talk about the projection fiber here. Projection fiber that identified on DTI such as corticospinal, corticobulbar, corticopontine, and thalamic radiations. And here's an example for the corticospinal, which is a descending track. This is the gray matter, and this is white matter. It's blue, right? You can see it going from the cortex to the spinal cord because corticospinal tract is the motoric tract. And if you could see this, there is something wrong with this because corticospinal tract mostly, like 80% or so, decussates. So it should be looking like this. Well, I'm exaggerating because it's not all crossing, but most of it decussate. This is a very important thing to look at because it can explain the correlation between the clinical manifestation and the abnormalities finding on the MR. I told you that internal capsule is part of white matter, and there are lots of fiber in the internal capsule as well. But is the corticospinal runs in which part of the internal capsule? The anterior limb, the genu, and the posterior limb. If you know, answer it in your heart. I'll just give you the answer. And this is the answer. It's posterior. Here is, this is the sample of the conventional MR. This is the internal capsule, the anterior genu, and the posterior limb. So if you can see this DTI, here is the CST, the corticospinal tract, which is on the posterior part of the internal capsule. And other projection fiber tract that are identified on DDI, such are corticobulbar, corticopontine, and thalamic radiations. You can see it here. It's a very complex one. You can screenshot it, save it, keep it, and remember it. And here is the color mapping. Anterior thalamic radiation here, see, this is the corticospinal. This is the corticospinal in the posterior limb here, and the genu is the corticobulbar. There is a frontopontine fibers and other corticofugal fibers in the anterior limb, and the anterior thalamic radiation also runs in the anterior. And the posterior edge of this internal capsule runs the optic radiation. Okay, we move on to association fiber. There are lots of fiber, such as the cingulum, fornix, SLF, ILF, fronto-occipital fasciculus, uncinate fasciculus, subcortical U fiber. Here is the illustration. There's this is the cingulum, which is like superior part of the corpus callosum, and this is the SLF, and this is the ILF here. Remember again that the association fiber runs backward and forward in the same hemisphere, so it is green in color, which is, look at this here, the green fiber here represent the cingulum. Here is the cingulum, the green. And another association fiber, this is uncinate fasciculus, this is SLF. The ILF runs inferiorly, You can see it here, the SLF, the uncinate fiber, and the ALF. Here is the inferior fronto-occipital fasciculus. It's extend back from the frontal lobe radiating into the temporal and occipital lobe. We have to know it because it's play roles in Alzheimer's disease, schizophrenia, depression, and epilepsy. Here is example of inferior longitudinal fasciculus. Superior fronto-occipital fasciculus connect frontal to occipital and temporal. The fiber arises from frontal cortex from a tight bundle at the level of anterior horn of lateral ventricle, runs posterolaterally by caudate nucleus and supromedial, and go up across the coronary radiata. This is the superior longitudinal fasciculus. This is the inferior fronto-occipital fasciculus, and this is the arcuate fibers. This is the inferior longitudinal fasciculus. Okay, then we move to U fibers, subcortical U fibers. Subcortical U fibers connect adjacent gyri here, just like this. They are variably related to higher respect of brain function. And delineation of U fibers is useful for diagnosis such as demyelinating, dysmyelinating disease such as like multiple sclerosis or even brain tumors, or also such as like PRES. The last fiber we are going to talk is the commiseral fiber. If you remember, commiseral between the two hemispheres. So you're looking to the right and to the left, it's going to be red color on the conventional DTI-MR. The most often commiseral fiber we are going to look, and most important thing that we have to analyze is the corpus callosum. Here's the corpus callosum in the red color. Okay, so this is a combined diffusion tensor imaging and volumetric MRI in a healthy young adult and in a 30-month-old boy with agenesis of a corpus callosum. So, if you can see here A and B, you can see the red color represent the corpus callosum is normal, which is the healthy young adult that I was talking about. A and B is the healthy patient, but can you see here? There is no red color such as this. There's no fibers that connecting between the two hemispheres, so no corpus callosum. So this is the patient that has agenesis of corpus callosum, and the props bundles that have anterior posterior orientation, which is if it's going forward backward, it's going to be green, right? It's not crossing the midline. Another example here, this is a 3 Tesla MR DTI tractography, and if you analyze this, this is blue color and this is going up and going down. Remember, this is the projection fiber. This is represent the corticospinal tract. If you still remember my previous slide, you can see here that there is no decussation on the A picture, on the above picture, there is no decussation from the corticospinal tract, while the B picture is the normal crossing corticospinal tract. So yeah, this is a real example from my previous illustration slide about the decussation from the corticospinal tract. What should we report? So we should report that if there's any displacement, there's an atrophy, or there's a congenital just like that, like the decussation, the agenesis, hypoplasia, hypogenesis, or others, and destruction. So here is the example of a corticospinal tract projection fiber. And there is something there that displays the corticospinal tract here more to the close to midline, and also destruction. This is just an illustration. This is another example. I got it from a journal. You can always Google others. This is a 36 years old male with GBM involving the bilateral frontal lobes and the corpus callosum. See the butterfly pattern. And on here in this image, the color map DDI show complete destruction of the superior longitudinal fibers on the right side, and also the corpus callosum we cannot see that anymore, and It's already destructed. Another example of an 18 years old male with diffuse brainstem glioma here. On the MRT2, you can see that this is a quite pathognomonic loop. Axial color map DTI showing loss of fibers involving the right cortical spinal tract. You can see there here. This is another case. If you can see this, this is an abnormal brain. The cortex is abnormal, and this side is somewhat uh, hideous. I mean, like this is big cortex, so thick cortex, like a polymicrogyria or something, and there is a huge ventricle. So big side, there is a cortical abnormalities, and the big ventricle. This is a hemimegalencephaly. But what's the important thing is it's not the hemimegalencephaly, but if you can see there is a track here that is abnormal. This is called hemimegalencephaly and aberrant white matter tract. Here's another um, example. This is a color-coded DDI map at the level of decussation of the superior cerebral peduncles. In a healthy subject, you can see this red dot in the arrow here because it's decussate. Decussation is going right to the left, left to right. That's why it's going to be red in color. However, in this patient here, we cannot see the normal superior cerebellar pedunculus decussation. And if you remember this is a Muller-Thud sign. This patient has Joubert syndrome. There is no red dot here. And this is, I think this one is the last. This is a segment of Aircraft Fasciculus. The Aircraft Fasciculus consists of both short and long tracts. The short tracts connecting areas within a region, while the long tracts connect between regions. So the Aircraft Fasciculus is a massive fiber bundle which runs along the lateral anterior posterior axis, connecting the Wernicke area, the speech perception area in the superior temporal gyrus, with the Broca speech production area in the inferior frontal gyrus on the left side. You can see here on the A image that represent the healthy arcuate fasciculus, while the B and C represent arcuate fasciculus in patients with schizophrenia with prominent auditory and verbal hallucination. I got this example from a journal that studies the arcuate fasciculus in schizophrenia patient with prominent auditory verbal hallucinations. And that study showed that patients with severe and frequent auditory verbal hallucinations, patients with schizophrenia, of course, have significantly longer tracts along the arcuate fasciculus, as well as an overall significant asymmetry with longer fibers on the left side. And if you can see here on this image, on the B and the C image, the thickness and the tract of arcuate fasciculus is longer. It's more huge than the A image, which is the normal healthy patient. So I just want to say that DTI is not only for displacement destruction because of a brain tumor or congenital abnormalities, but it also can explain the neuropsychiatric problems, such as like this. Well, I think that is it. And thank you. I hope you enjoy it.